Dr. Forman, Eric, welcome to Inside Reproductive Health.
Thanks for having me. I really enjoyed your shows and your work, and I'm happy to participate.
I wanted to have you on the show because for being a very soft-spoken guy, you're also a very popular guy. And I've always found you interesting because you appear a number of different places. I think you're part of one of the advisory boards or maybe the scientific committee for MRSI. Is that right?
Yeah, I'm on the executive board for MRSI, which is a great meeting that's also done a great job of transitioning in this era of COVID to have a virtual meeting last year, and we're having several virtual meetings throughout the year. So it's a good venue for people who are listening if they haven't participated previously.
That's where we met in person. So, and I've seen you on a few different committees, a few different subgroups, and you have an interesting career where you worked in private practice. You built a name for yourself. Now you're at Columbia in Manhattan. And so I wanted to start with, and that's what we're going to explore during the show, is the difference in potential career paths for people in both of those avenues, how they're changed, what's on the landscape for them. But how did you make your first decision coming out of fellowship? Why did you choose private practice to start?
Well, I think part of it goes back to even my training, and part of why you know me and I've met so many people, as you say, is I think I was fortunate to have an amazing training experience with Richard Scott, who's my mentor and a real leader in this field. And I had an opportunity to go to meetings like MRSI, from my first year of fellowship, and there was really no limit to meetings and presenting research. And I took as many opportunities as I could to meet people and hear about what they were doing. Even from the time I was interviewing for fellowship, even when I kind of had an idea of where I thought I was going to go, I loved the interviews and just learning about different places and different people, and even the other fellow applicants. I'm still, friendly and collaborate with many of them, like more than 10 years later now. So I landed in fellowship at Reproductive Medicine Associates of New Jersey through, at that time, UMDNJ, Robert Wood Johnson Medical School, which became Rutgers Robert Wood Johnson Medical School. Now they're affiliated with Thomas Jefferson, but the vast majority of the fellowship was at RMA. And I chose that fellowship because it really was a unique paradigm at that point that focused a lot on the embryology lab and giving fellows real clinical hands-on experience that could potentially set one up to become even a high complexity clinical laboratory director, which came later. So I was really excited about this new fellowship, this new way of training reproductive endocrinologists, because I knew that in vitro fertilization was a huge part of what we do, clinically, even though a lot of the fellowship time is spent learning other important things and doing research projects that may be less sometimes directly, but sometimes not so directly related to IVF. Still, the vast majority of reproductive endocrinologists spend a lot of our time with activity related to IVF, related to the lab, and really being intimately involved with what goes on there, I thought was critical. So I had a great experience, and then I had an opportunity to stay on, and I didn't really maybe in retrospect I should have, but I didn't really apply or interview anywhere else. Everything was great, and I didn't have to move, and I knew everyone. I knew the nurses, I knew the embryologists, I knew, through my fellowship, rotated everywhere. So it was really easy to transition into an attending, because that's one of the biggest transitions, I think, for reproductive endocrinologists. We have all these, transitions: graduating college, medical school, residency, fellowship. Then as an attending, now you have to take all of that and, you're never on your own completely, but seeing your own patients and integrating what you've learned through all those years to take the best care of your patients, but also now with a new group of people who maybe do things differently. So it was a pretty seamless transition because I knew how the system worked, and that was great. And I used that time to stay involved with the lab, and I was able to become an HCLD lab director. So that really, I think, summarizes kind of how I ended up staying in private practice. And I didn't think about it so much as private practice. More, this was a very busy clinical practice that's very academically oriented and did research and fit with my goals really.
Yeah, the division isn't always so stark. There's often
Yep.
a Venn diagram. We've had Michael Elper on the show to talk about Boston IVF's relationship with Harvard and Brigham and Women's, and so you are in fellowship in conjunction with a private practice. What you talked about, one advantage being that you had a seamless transition when you chose to stay with that group, but what are some advantages and disadvantages, if there are, of having that type of relationship where because sometimes there's just the university and the health system, sometimes there's exclusively private practice. What is the benefit of a relationship like where you started, or disadvantage if there is one?
Yeah, I mean, so again, I mean, one of the advantages of a private group is that you can be more autonomous with decisions, like even things as simple as where you buy supplies or where you buy furniture. Even when you're part of a bigger institution, often there's preferred vendors that you have to go through, although that's not always set in stone. Again, you can make a case for why something is important and benefits the division. And again, we've been successful at changing things here and doing things that we think benefit our division, but it's just kind of a different path maybe.
So you've been at Columbia for a few years now, and you are in a more senior role. If someone from the university, the administration comes to you and says, well, Eric, we've got the opportunity to merge in our program with a private group, how do you advise them on that?
That's a good question. I mean, I think it would, I'd want to know like what is the advantage? What are we gaining from such a merger? Is there something that we are not able to do right now that we would be able to do? That, there have to be some benefit to us, to our division, to our staff and our patients, and the department or the medical center for them to do it. So, if it maybe expanded our reach beyond, where our current footprint is, and we could take some of our approaches and spread that beyond, I mean, that might be a reason. But I mean, I think, as you said before, some of these lines are sort of hazy, and I don't necessarily, I'm not sure that there are so many things that a private practice can do per se that we can't do. And I think we've tried to sort of merge the best of both worlds. That, I think a common perception is maybe more that private practice focuses more on like the patient experience and outcomes and quality, whereas academics focuses more on research and education and things like that. And I don't think that dichotomy is necessarily so clear. Like I said, I had great research and training at a more private hybrid kind of practice. And I think we've done some things and continue to try to make the patient experience, as good as it possibly can be. And, from day one that I came here, never had the attitude that it's an academic practice, so that means that we don't have to provide as great or better service to patients as any private practice. I mean, I think that perception is out there that it's like a big hospital, a big medical center, and you can never get through to someone, or you don't know who your doctor is, or they're doing research. But it doesn't have to be that way. I think we can provide the best care that patients expect and be competitive, from a clinical standpoint with any practice. Similarly, I think private practices, if they have the right focus, can educate, and they do, and train fellows and residents and medical students and do amazing research. So I don't think it's as clearly defined. So, I mean, my advice would probably be, again, why do we need to do this? Is there something that, that we're gaining?
It sounds like you would need to be convinced of the benefit. It doesn't sound like you readily see the benefit.
I think, yeah, I mean, I think that's fair to say. I mean, I think we definitely have always room to improve, but I think we're trying to do that from within and looking at ourselves, looking at our practice, continually evolving and improving. And I would need to hear, why some outside entity is necessary or is going to make that better.
So you felt that, well, just in speaking in broad strokes, you're talking about that it's often the case where private practices have more autonomy and academic institutions have less in making this decision where you're at right now. You don't feel that way from day one. You feel that you've been able to implement changes, or at least at least give your input. And you said it doesn't have to be that way.
Mm-hmm.
How have you been able to what changes have you been able to bring to bear, or improvements? Because I think people often do think of academic practice as being a lot more rigid. And I can tell you from experience that I've had enough experience that validates that, but I don't think it has to be an axiomatic truth. And you might be
Right.
able to
Right.
shine a light as an exception. What have some of those been?
Well, I think, part of why I chose to move, I was doing well, like you said, and I was, I think, taking excellent care of a lot of patients and at a very good center and involved in research and going to meetings and leading, or helping to organize meetings. So I was happy where I was, but this was a great opportunity, like you said, to have more of a leadership role, which I think, a lot of, I thought was important, but also to improve and shape things. And it's not just me single-handedly at all. There's a whole team of us who have really made a lot of changes, from Zev Williams, who's a division director and recruited me. Colin Thomas, I know is our COO administrator, and our whole team has had this vision of we have to improve our center, we have to improve the patient experience and not stop and keep improving. So I knew coming in that they were receptive to change. So that's maybe different than some other situations where someone takes a new position and things are running smoothly and going a certain way, and maybe more difficult to make broad changes. But from the beginning, we knew that we had to change our physical space, and we built out a new clinical space, a new IVF lab. We changed the culture just of how we organize our teams with more clear defined teams that patients know, who their doctor is, who their nurse is, who their financial coordinator is, that, we try to be available. Patients want to hear and have access to their doctor. So, being even willing to give out email addresses and communicate directly with patients. I think our patients, in nowadays, are not so accepting of hearing that they have to wait a few weeks to talk to their doctor. If they have a question, they want more direct access. So we changed, again, a lot of these things. Then from the clinical standpoint, we, as a group, reviewed our protocol, the way we do things medically, the way we treat patients, our lab protocols, and tried to sort of, merge and come up with best practices that we all agreed on, some of which things I had seen at a successful place, some of which was already established and doing well here, some that others had seen in their experience. So, but I think in order for that to work, we needed buy-in from our doctors, from our nurses, from our management, from the university, that change was needed, and that we could make changes, and then we can evaluate how that was doing and make more changes. And so that's kind of the, in big brush strokes, like you said, like the model that we've taken. And that's been, in the beginning, it was pretty daunting, because it's easier to work at a place where things function, pretty smoothly, and how things work. Like I said, I, knew everyone. To come into a place where I almost didn't know anyone and then have to really reorganize. But if you can get that buy-in, and everyone on board, everyone have input, it really can work really well. And that's been very rewarding experience. And it definitely would do it over again if I had to go back in time.
Talk about how you get the buy-in. And I'm not necessarily suggesting this example, but I'm just giving you one example of someone that I knew that worked in academic REI practice that was very successful on social media, believed it to be a very useful tool in building rapport with their patients and not just recruiting patients, but educating them, building rapport with them. And it was very useful. And the university said you can't have any you can't have any social media content that's affiliated with your work here in any way, even if it's on your personal channel. And I think of just one example like that, but let's say if you wanted to invest in patient experience training, or you wanted to create new resources for patients, or many clinics don't even have their own website. They're just buried on a backlink of the university's site, and they can't even get a Google My Business listing. Talk about how would you advise someone on getting buy-in for those changes that they want to see? And those are just a couple examples, but the examples that you gave are also valid.
Yeah, that buy-in is like more high level, and I think I mentioned before, our leadership team, like Colin and Zeb, I think have done a really good job at advocating for what we need. I think that fertility reproductive medicine, fertility clinics, we're trying to practice in a field that's very competitive, especially in New York City. There's a lot of options, and so that's a choice. Do they want to have a really well-rounded department with a great reproductive endocrinology division that the heart of that is IVF and an IVF lab? And if they do, don't compare us necessarily to other departments or divisions that maybe function in a different way, but we have to look at what is our competition doing, and what kind of website do they have, what kind of patient services do they have, do they have a presence on social media? So I think that getting that kind of buy-in, that this is what we need to do to thrive in this space, and just again, to some extent, you have to make a strong case and be persistent and hope that you have receptive leadership, which we did, because they were committed to improving this division. And we saw that. That's why I came here. I think on my level, I'm the medical director and I'm the lab director, and my focus is more on getting the staff, the doctors, the nurses, the embryologists to buy into what we wanted to do. And that, I think, comes from experience and integrity and leading by example, I like to think of it. And also, honestly, a little bit of luck too. I don't want to credit luck, but there's some anecdotes I remember, just when I first came here, where they didn't, maybe did things a certain way, and I knew we could do things a different way because I'd seen it and done so much in my previous experience, and went out on a limb, rather than, again, on the one hand, you could go with the flow and say, I'm here now and this is the way they do it. Or you could say, I know that that's the way it's been done and it can work that way, but we can also do things a different way, and then actually do that and get a good result, and then use that as an example to kind of get people to buy in. So first, I think you have to convince people, have to believe in you, that you're competent and you know what you're doing. And that goes from procedures and, other doctors seeing that you know what you're talking about, you know what you're doing. And so I couldn't have come in here, I don't think, straight out of fellowship, even though I had a great training and experience. I don't think I would have been confident enough to go into, meetings with other doctors who had more experience than me in terms of years, and get them to buy into changing our protocols, changing our way of doing things, or getting the lab to, the embryologist to buy into changing some of the things that they were doing. But after 4 years, which isn't that long, but 4 busy years doing, managing lots of cycles, doing lots of procedures, working closely with the lab, and that gave me, I think, more confidence that I could come in and say, like, let's do it this way. And even if it didn't work, because again, I said I got lucky that a lot of things I did, worked out well, and we got some good outcomes, and I think that helped. But even if it didn't, I think I would have had the confidence to stick with it, and the next time it would have worked, but I wouldn't have given up so easily. But I don't know if that makes sense. But
you mentioned our mutual friend Colin Thomas, who's the administrator, and Dr. Williams, who's the division chief. And of course, when anyone goes anywhere, well, presumably they're doing some sort of feeling it out to see what it would be like to work with those people. But was their ability, because you talked about their ability to work with the leadership and the administration of the university, was that specific tenet, my administrator and my division chief's ability to work with the university, was that on your radar at all when you were interviewing them?
A little bit. Again, I think I definitely wanted to go to a place that, that one, was open to change and wanted to get better. And, from our chair, Dr. Mary Dalton, who's a very well-known, well-respected chair, maternal fetal medicine, she was very supportive and still is of our mission to continually improve and provide the best fertility treatment, care, and experience for our patients. So, it was definitely, a factor that I wanted to be able to work with, the other leader, management team, and feel like we had the support that we needed.
There's a lot of REI fellows that listen to this podcast, so I want to try to give them some actionable career advice. And I'm going to ask you yours. Yeah. One piece that I thought of was that if this is a concern that people have, and I know that it is sometimes a concern of how rigid will this system be, will I be allowed to bring my input? I think it's a good question for the division chief for whom someone is interviewing to say, tell me about a time where you had to persuade the administration of something and that you had to implement something that previously had not been implemented. I think that's a good, that's one good question for people to be able to ask, to kind of get an idea of, one, how much your division chief wants to implement some change, but two, how it might or may not be possible, depending on how deeply they sigh when they respond. But for you, having been in both types of practice groups, what personalities, or maybe not personalities, but perhaps what type of profiles do you feel do better within each?
Yeah. Before I get to that, I want to also mention, just like, we'll get, if it's okay, to sidetrack for just for a second, how these lines are kind of blurred. There are also, I think, private practices that can be rigid and, are large and in some ways bureaucratic too. So
even the ones that aren't, even the ones that aren't large and aren't necessarily bureaucratic can be every bit as rigid.
There are places where, there's things that they do and you might think we could do things differently, but that's the way it is, and it could be very difficult to change. And that could be private practice or academic. I think that more just reflects the culture of the organization and the leadership of that organization. So I think those are I think important things to think about when you're, applying, as you said, for a job. And, so what kinds of, I think, again, maybe I'm idealistic, but I think you can do well. I think you have to be obviously like hardworking and passionate and care about your patients and, good at what you do. And if you do all those things, like, you can be successful in either place. And I think I was doing well where I was, and I think I would have continued to do well and grow and expand, my abilities. And I think here, similarly. So I don't think there's any place where you can do well by, not working hard. It's hard work and it's a busy career, but it's very rewarding. Our patients are very demanding, but they're going through a very stressful experience, but it's, again, very rewarding to help guide them through it and, minimizing the stress and burden that they have. So again, I think anyone who has the right attitude can do well at either place. But I guess,
do you interview physicians when they're applying for a position at Columbia? What do you notice? What are some of the things that come to the top of your head of what makes a candidate stand out versus one that you think, maybe not that one?
I mean, I think as you mentioned earlier, like, make a name for yourself. I mean, I think one of the things that I really like about our division is that we all have a certain focus or niche, you could say. Like, Dr. Williams really focuses on recurrent pregnancy loss and complicated cases. Paula Brady has focused on our oncofertility. Sinem Karipchin is focusing on our more prevention of genetic disease, single gene PGT. Roger Lobo, is well-known expert on PCOS and menopause. Brianna Rudick manages our third-party team, and we have a few other doctors as well. But I mean, I think having like a passion, an area that you're really interested in, I think is really helpful to maybe differentiate yourself in a, very crowded sometimes field or market. That's something that stands out. I think someone who can get along with other people is really important, because these, our clinics, our centers now are, complicated places with, multiple components with your own team and other teams and labs, and, being able to interact and get along with everyone, and we're, a growing center. We now have 10 doctors, and, we want to have, like I said, each doctor have their own identity and their own interests, but also not have like 10 separate clinics functioning autonomously, because that could kind of be chaotic. So someone that can get along, like, come to consensus and say, this is the way we do things, but it's not so, but also is, intellectually curious and innovative and, thinking, because we are going to reassess everything we do. And if there is a better way to do it, we'll change it, but we'll all incorporate that into the way we do things. So those are some of the things that I think about. And someone who's, again, really passionate about this field. And, like I said, even if we do research, even if we're in an academic place, we spend a lot of time talking to patients, answering their questions, counseling them. So someone who is good with patients and, really understands, like, that, we have to be available, and, have to be available, to patients, not 24/7, but, that we have to communicate well and have systems in place where if patients, again, have questions that they want their doctor to answer, that you're available to do that.
In some cases, many people make the argument for private practice that they get to determine that, not so much against academic medicine, but against networks, for example, that I don't want to be a part of a fertility network that is either publicly traded or partly owned by private equity, because I want to be able to make those decisions. But I never hear people talk about that dynamic in academic medicine, whether they feel like someone's telling them or not. So what is it like in academic medicine? Is it on either side of those two, or is it in the middle?
I mean, I think it just varies so much that there's so many different kinds of models where, some REI divisions are, more integrated with the academic medical center, and like you said, their website is buried, and they follow exactly the way everything else is done. And there's others that are allowed to be somewhat more autonomous. So I don't know that there's an answer that applies to all. I think there are some academic settings where it probably is difficult to change things, and then there's others where the leadership has given the division more autonomy, and then depends on who's making those decisions. Is it just one person like the division director who sets everything from above, or is it more collaborative where all the doctors have input? I think that's true in private practices as well, whether it's a network and there's some protocols or ways of doing things that come from above, or it's even a smaller practice, but there's the one person who founded it or something that sets everything. So again, I think like I said before, a lot of these dichotomies, I think, are not such really dichotomies. I think these kind of dynamics can exist in either setting. I think one thing that's different, though, I mean, at least as a fellow coming out, thinking about, that idea about, being part of a practice, or is it going to be taken over in some way by a larger network or private equity? I mean, I think there have been a lot of changes, as probably better than me, in this field. So that maybe creates some uncertainty. Academic center, there's always uncertainty in everything, but an academic center, I mean, I think it's less common that it's taken over by some outside entity, unless, like you said, there was it happened. But
yeah, I was going to say, is that still true? That maybe segues to a question I have about what's the future for academic. Are we going to see more of that? We've seen some of that where we've had we've had REI divisions essentially acquired by fertility networks. They maintain their relationship with the university. And I'm not talking about the fellowship programs necessarily. I'm talking about the IVF centers of REI divisions in academic centers being owned by private equity. They still have an academic, maybe a research or a teaching obligation to the university, but their salary comes from the network. And I wonder, is that the future of academic practice? Are we going to see lots of IVF centers being sold off or partly sold off because it's like the health system's like, what, we're spending a lot of our attention on the oncology division. That's where we make most of our money. We could make more money by just letting this part be partly controlled by another entity. Is that the future of academic practice? And if it isn't, what is?
Yeah, I mean, it's hard to say, but I think, if this private equity or, is coming in, it must be because they view it as a profitable area of medical treatment, and otherwise they wouldn't go into it. So it just, to me, doesn't make sense, like, why the university or academic setting would want to give that up. If they can't do it well and it's failing, that's a problem. And, I think then the choices either are to just, give it up completely and not have, fertility or reproductive services, or to improve it and maybe modernize it and, be able to compete with those private practices, or to spin it off, like you said. I mean, I think the model that we have of being able to make improvements and work within the medical center, I mean, I think it could work, and I think there's advantages where, I think we know we have to train future reproductive endocrinologists, and that's usually done within an academic setting. And if we grow, hopefully some of those people will stay and Like I stayed where I trained, and some will go and train, move and train in other places. But we potentially, I think, have some advantages that private practices don't have, which we haven't talked about yet. But we have name recognition. I know you do a lot of marketing, but if you did a survey of people before they ever know that they're going to need fertility services, people have heard of in Columbia or Northwestern or Stanford, like they live in that area where there are private practices or networks that those of us who are in this field, we know these names and they're very brand names to us, but are they to someone who's just trying to get pregnant for a year and hasn't, and ask their doctor if that's how they find, there's different ways people find us, but that's an advantage that I think we can use to improve our centers and make them better. So there's usually OBGYNs within the academic center who are seeing patients who are trying to get pregnant and wind up needing fertility services, or single women who are thinking about preserving their eggs. And that's, a referral source that outside private practices, you have to work really hard to make those connections. And I did when I was in private.
Even then, it's not always guaranteed that referral source. I've looked at some academic centers' referral patterns, and it's like, wow, you have a fraction of what your health system is doing in terms of, OB deliveries, for example, or you're just total OBGYN volumes. You have a much smaller fraction of that than against the marketplace. So I don't know that it's...
I'm saying you can't use that and become complacent and say, oh, we're Columbia and there's all these OBGYNs, so we're automatically going to get those patients. No, that's not what I'm saying. I'm saying, though, that if you do provide as good or better care than anyone else, and you still have to internally market and give patients the best experience, but if you get to a point that you're just as good or better than anyone else, then I think you can accrue a higher proportion of those internal referrals and have those patients stay within the system for delivery and other medical care. We get patients who, they go to Columbia for their other medical care and they want to keep everything within the same system. Yeah, if we didn't provide good services, they wouldn't stay, or their doctor wouldn't steer them here. But because I think we do provide really great care, it's easy to stay within the same system. Same as when I'm, referring someone who doesn't have an OBGYN or, just moved to the area. Obviously if an OBGYN refers us a patient, they should stay with that doctor. They have a relationship. But if they don't have an affiliation, I know we have great obstetricians and maternal fetal medicine specialists and minimally invasive surgeons. And, I would, refer to those people. So it's, helps the department in other ways versus, potentially missing out on some of that if you just, use the name, but you're sort of separated. Maybe there's not as much of an incentive to try to keep patients within the system. So I think a case could be made that if the time and resources are invested to make the academic practice as good as it could possibly be, that benefits that division, it benefits the OBGYN department, it can benefit the whole medical center by keeping more services within. Again, I think that's a model that that can work and make sense. I don't know, it's hard to predict. I'm not a hospital administrator. Maybe you're right. Maybe it's such a small piece of compared to cardiology and oncology. But I think if you're looking at trying to just overall provide the best care and be as productive as possible, I think there's a role for keeping fertility treatment within an academic setting.
You mentioned that there were some other advantages. What other advantages would academic centers lose by selling off to network or breaking off?
What would they? I mean, I think I was thinking more, of like from a physician standpoint first, like, in choosing to work in a place, again, I had a very rewarding experience, and I think it can be, but there's also some advantages of being part of a larger department and medical center that, it's easy to get other opinions. Not saying you couldn't do this outside, but you're, more separate than, I have dozens of other doctors within this department. And then even within this medical center, if a patient, needs a medical endocrinologist, a neurologist or something, to easily be able to look up and reach out to someone in that department or division, or collaborate within the medical center, on research ideas. I think, so there's, and just again, I think we all like want to feel like we're part of something bigger and greater. And I've been feeling, again, I think the academic center provides an important role in, in training and service and caring for patients in a community. And it's rewarding, it's rewarding on our level to take care of patients and help them build their families or preserve their fertility, but it's also rewarding to know that we're part of a bigger center that has a really important mission. And again, I think is stable. You're right. Again, it's possible. Anything is possible that it could be sold off or spun off, but, it's a large university that hopefully is like not going to get sold or bought or go out of business or something like that. Even though things can change, I think there's some stability there. So, that's something that, I think about when I, talk to other doctors, or fellows applying. I think a common question that comes up in private practice revolves around like partnership and ownership and future. And I think it creates a lot of stress, and a lot of time is spent on this topic, and I don't think most of us didn't go into medicine to like own a business or run a business. That's just my opinion. And I think we went into it because we were interested in some, in medicine in general or some area of it, or again, becoming a physician. And it's kind of evolved that those of us who are in this field the way it is, that has become, and probably in other areas as well. But we know, there is definitely a business side of medicine, but I feel less stressed. Like I know I'm never going to own Columbia, like the trustees of Columbia University, or who pay me or whatever. So like, but there was this discussion of like, when do you become a partner? What does that mean? How do you pay for that? What if you change your mind? What if you don't want to do it? And how clear some clinics, it's very clearly defined. Some clinics, it's not so clearly defined. So I think to some people that's really important, and they want to own something, and and others, it's I think more just the status, like that's what it's thought like you should do if you've been out for a while, and you should have that because that's just the way our field has evolved. But I think it's in some ways, being part of an academic center, as long as you're, compensated fairly, and that's, a whole nother topic, but as long as, again, you feel like you are, you're doing well and you have good benefits, and I think there are like really good benefits to being part of a large organization, it takes that stress off, that rather than worrying about you have to take a loan to buy into a practice or something, it's not even a thing really, for better or worse.
I think you made an impassioned argument for the benefits of of academic REI practice. how would you like to conclude? Is there anything I didn't ask you that you'd like to add?
I mean, I don't know if this is relevant, but I think there's some things, and I can give one example of like HIV, which was an interest of Columbia even before I came here, where there may be, you know, some areas that are kind of small, like a small number of patients may be affected by, and it may just be, you know, easier or less risky for a private practice to just not deal with that. There are a lot of private practices that just say they just don't treat patients if one of the partners is HIV positive, when really, like, there are protocols out there that are safe, that it could be done, but it's a little bit of extra work and maybe some risk. Again, although I think that's really overstated even if you have good protocols in place. But I think, in my opinion, that there's some inertia. Like, we don't do that. I mean, it's not like it's going to generate a huge amount of revenue. We don't really need to do that. You know, maybe leave that to the academic center. Well, and we do that because we feel like, again, I mean, you can safely treat these patients, and why shouldn't they have access to care? And I'd rather have a broader net and, you know, still safely and have protocols, but be able to take care of different patients that maybe fall through the cracks or maybe aren't profitable. But if we don't do that, you know, who will? So, and it also makes it more interesting, I think, than, you know, than having certain rules like we don't do that, we don't do that here. Let's see if we could find a way to do it, because I think there's a role for it. So I think, you know, as I mentioned before, I mean, we went into this to help couples, help individuals build their families, and I think, you know, all of us are intellectually curious, and I think it's an interesting environment to practice in when we can solve problems and, you know, expand access to care and maybe not restrict it because it might not be profitable for the network or whatever that owns the practice.
Dr. Eric Forman, thank you so much for adding your perspective on Inside Reproductive Health.
It was good talking to you. Thanks.